All right, it's my favorite time of the week. Hello, Mac.
Look at this fresh face. Oh, isn't it wonderful? Love
Coffee
it.
and makeup, it helps. All right, so let's
Well,
continue our
let's
conversation.
get started. I got a question for you.
But
It's been a long time since I graduated from dental school, and I don't know about you. Didn't learn anything in dental school, which we've talked about over and over and over again. And appliances, dental appliances, good or bad. What did you learn? Because I didn't learn one single thing.
oh, I learned about the almighty night guard.
The night guard.
Yeah, the
Oh, you
night guard is like the Robitussin of medicine. It fixes everything. The night
takes
guard,
care of everything.
it takes care of everything. It'll make you rich and make your hair grow too.
So how did you go about making or what was the idea behind the quote night guard in dental school?
Well, first things first, we were never even taught how to make a single night guard. So we were just told that if you see a patient that's grinding their teeth, okay, like they have wear on their teeth or broken teeth a lot, then you make them this acrylic based appliance that you stick, first of all, a mouthful of goo in someone's mouth so you can get the imprint of their teeth. And if they survive that horrible gagging experience, then you can provide them with this nice bulky night guard that they can wear in their mouth when they sleep on their upper teeth. And I did make those for probably about the first 2 to 3 years of my dental profession because I am in Northern Virginia, just outside DC. And I'm like, my first year out, I'm like, why on earth is everybody grinding their teeth? So we're making night guards right and left. And in different offices, people will charge anywhere from like, a couple $100 to like 600 plus dollars for a night guard, which I think is insanely expensive for that ridiculous appliance. But if I can open up and tell you how I really feel, uh, but that's the extent of what we were taught is to make a night guard for people, and I haven't made one in 22 years because I know more.
So I didn't learn about night guards. I had to wait until I graduated and read dental magazines that talked about night guards.
Wow.
Just send your impressions to a lab and they'll send you back, quote, a night guard to help people stop destroying their teeth. I mean, how draconian is that? And so what it ends up is that they become, a pop. You know what a pop is, right?
You can get them on
A piece of a,
Amazon, plastic
a
ones
piece of
now.
plastic. It's just a
Yep.
piece of plastic.
So I
And
wrote an article for the Washingtonian magazine near me, and I think the title of it was like a night guard, is it helpful or harmful? Okay. And again, no disrespect to our colleagues that make them, because again, that's all we know. But a couple of things I wanted to highlight is that, okay, you can literally put anything between your teeth at night. It doesn't have to be a night guard. It could be boiling bites from a store, whatever, a piece of cotton, so long as you don't choke on it. You could put something between your teeth at night so you don't grind enamel to enamel
sure.
surfaces, wear down your teeth. And that can be helpful if that's the only issue, but we have to understand why someone might be grinding. And as we've talked about in a previous podcast, most
Right.
people who grind their teeth or what's called nocturnal bruxism. Um, they have an underlying sleep breathing disorder of some sort. So I think it's prudent if you are a grinder to get a sleep study done and rule out you don't have apnea or some kind of upper respiratory syndrome, distress syndrome. But anyway, so if you're making people on night guard, which I was just saying, it's thick and it sits on your upper teeth. Well, you are occluding or decreasing the amount of space someone can breathe through their mouth, because if people are grinding their teeth, they're typically some kind of mouth breather because they can't breathe through their nose. And now you're making their airway even smaller. So you can exacerbate or worsen a sleep disorder breathing issue. And better do your due diligence and get people tested correctly and diagnosed correctly. So that was night guards is something I don't make anymore. If I want, let's not get into that. I feel like I cut you off. You wanted to share something.
Okay, so then let's look at it this way. If my eyes, and both of us wear glasses, If they're not working correctly, they're not in harmony with what they should be, whatever's retina's not working, whatever's not working, you put your glasses on and it corrects your vision. But it didn't correct my vision. It just allowed me to see better.
Well said.
Okay. So if you have the trifecta, one, two, or three of them, and you have the mindset that things, stress and stuff that work against you, and you put on a well-made orthotic, you are compensating for your eyes not working or your teeth not fitting together.
Mhm.
So that's the concept behind the orthotics, which are neuromuscular orthotics that we make today.
Mhm.
A lot of you listening have a drawer full, a graveyard full of appliances that did not work. So I'd like to give you part of my history since I've been around so long. So in 1977 at the Pankey Institute, I learned about a midpoint appliance. Okay, a midpoint appliance is pretty easy to understand. If you put your fingers on your temples and you bite down, you can feel the muscles move. But if you put a pencil between your front teeth and you bite down, you no longer feel those muscles move because you've changed the leverage of the way that you bite. So there is a place for midpoint devices. So a guy I know took that concept and turned it into the NTI. And most of you people who've been to the dentist had heard of an NTI. So what does a midpoint do or an NTI do? It keeps your teeth apart, just like you said. Put something between your teeth and your teeth don't touch, then you don't have posterior interferences.
Mhm.
You don't have a torqued mandible, but you still have a deficient maxilla and that jaw is not in the right place.
Mhm.
I also learned an appliance called the Tanner appliance. And the Tanner appliance was made to take care of posterior interferences and was made to take care of a a torqued mandible. At that time, I was unaware of the deficient maxilla. And of all the things we're talking about, Pam, you and I are talking about on the trifecta, the ones the dentist cannot wrap their head around is the deficient maxilla. And that's your expertise of preventing young children from growing up to be adults and having a deficient maxilla. And it is the number one thing that separates what we do from what other dental occlusal camps do, like Pankey, Dawson, AAOP, the list goes on
Right.
of the different camps. And my whole goal on writing my book and what I'm doing is getting these camps to where we find the likeness that we do instead of the differences we do for the benefit of TMD sufferers.
Yeah, for people, man, put your ego away,
Oh,
amigo.
way.
So listen to this. I just came back from a holiday and towards the end of my holiday, I went hiking. And I was on the island of Madeira, which is absolutely magnificent. And it was an early morning hike, to go see the sunrise at the summit of this extraordinary place. Anyway, one of the other five hikers I was with, she was a young new doctor, pediatrician. Okay. And she sat next to me and she's like, "What do you do?" And I'm like, "What do you do?"
Poor
And
thing.
she said, "Yeah." The minute she said she's a pediatrician, I looked at her, I go, "I am so sorry for you because we're going to spend the next 6 hours talking about how you should unlearn some of the nonsense they taught you in school and what you should really start looking at." And the heartbreaking truth of it all, it makes me so sad. It really does, is that they don't know, excuse me, shit about airway. They're not discussing the tonsils and adenoids to the level that they should, other than how to surgically remove them if it comes to that, which nobody does. It's very seldomly done. She talks about like, okay, yes, we know that you have to wait till there's 8 or 9 ear infections. And then you try tubes first, ear tubes,
Yeah.
not correcting the problem,
Yeah.
first of all, seeing what that child is allergic to, managing that, and then fix the hypertrophic or overgrown tissue that blocks or occlude their airway. So needless to say, I hope that my annoying self made an impact, because just like this podcast that we're doing, if we can turn one ear onto what we're talking about, get people to open up about what they're seeing and how to look at people, that will just, that's extraordinary. That's what this is all about.
Absolutely. So the appliances, let me back up.
Yes.
You mentioned that you take impressions of upper and lower teeth and take a bite when you're making your quote night guard.
Or I
Well,
did.
basic, yeah. Now you have digital scanners and the game has changed. Even 3D printing has changed the game. It's going to really change the game in the future. But taking a bite, when you made one of those appliances in dental school, you just had them close all the way down and squirt material
Correct.
in between there. Okay.
Correct.
So all that did is recreate the relationship between the upper jaw, the incorrect relationship between the upper and lower jaw. So it didn't do anything. Pete Dawson, Dr. Pete Dawson is probably one of the most famous dentists in the world. And he was the guru of all TMD. So Pete and I were good friends. We were in business together. I spent a tremendous amount of time with Pete. What he did to find a bite is to manipulate the jaw, which brought the condyle back. He's the guru. He's the master. Nobody is going to dispute that. Nobody's going to dispute and go against Pete Dawson. So then along comes sleep dentistry, which you've mentioned almost on every podcast. And sleep dentistry is airway. Sleep dentistry is that this area collapses, the joint collapses, the teeth, all of it collapses, no airway. So the solution dental-wise is a mandibular advancement device, which brings the lower jaw forward, opens up this throat, but guess what else it does? It brings the joint down and forward, which
So
is against, pardon?
So it gets the tongue out of the throat and it decompresses the joint, like you said last time in the last podcast.
Right.
Yeah.
But as far as Dawson is concerned, who is now teaching, the Dawson Institute is now teaching airway and TM and sleep dentistry.
Interesting.
They had to bring the joint forward. That sleep dentistry is leveling the field of all of the different camps, guys. And excuse me for the listeners if you don't know these camps, but the dentists know who they are. This is where you get your advanced training. All of them are bringing the joint forward in sleep dentistry. Why? Because the area has been compressed. Why has it been compressed? Because there's a deficient maxilla. It all goes back to the deficient maxilla, which dentists will not listen to. Pediatricians will not listen to.
Right.
Lactation specialists will not get their pediatricians to listen to.
Right.
And it
Right.
goes on and on about the dangers of the unawareness of TMD. So let's do the battle. Let's fight this unawareness.
Yeah. So I'm trying to stay on focus, because now you got my mind thinking about the tongue and lactation consultants, and I can go on and about that. We'll talk about myofunctional therapy, lactation consultants, and frenulectomies, which are tongue releases, at another podcast for sure. I've already got that down for us. But to go back to the different appliances, um, what started as a night guard, some people do the NTI like you brought up. We have to, if a listener is trying to think like, what are they talking about? Okay, what is the chief complaint? If a patient comes into my office and they're like, I need something because I'm wearing down my teeth, I'm going to go through that whole differential diagnosis like you talked about. I'm going to check their muscles. We're going to take a 3D scan. What's causing them to grind? Well, let's say they know they have a midface deficiency and they have airway issues, but they're like, I don't want to deal with that right now. I don't have the time or the money or the patience or all three to deal with it right now. Well, then we're going to make them very thin appliances like Essex retainers, which look like Invisalign tray. But if a patient comes to me and their chief complaint is, hey, I think I'm grinding and or I have sleep issues, we're going to talk about the different appliances that you just discussed, mandibular advancement devices. And again, listeners, there's so many things out there. It can get completely confusing and you can find a lot of things online. please be careful, because if you doctor yourself, you can cause changes in your bite in a really negative way that can start impacting other things. So if you're trying home remedies, make sure you're discussing it with your dentist if that's the direction you want to choose, okay? But whatever those oral devices are, they're somehow getting the tongue out of the throat. The ones Mac and I would make are ones that not just open up the airway, but also help the TM joint, because we know
And the
those,
muscles.
again, yeah, the muscles, the TMJ, sleep apnea, they're married to one another. So we're trying to treat both, even if the conversation didn't start there. And then there are appliances that are made for TMJ sufferers, like people who just are coming in with headaches, all the stuff that we talked about in the past, eye issues, posture issues, ear issues, etc. And those are the ones that we're creating. They're typically called orthotics, and they should be on lower teeth, and they're the ones that make your bite, your mandible, your lower jaw in a balanced position for your muscles. It's a physiologic balanced position. Different dental camps will have different ways of doing it, but our philosophy is, again, to find out where the muscles are comfortable, using electromyography to measure that, and then where is the joint postured, using CBCT, which is that 3D scan we talked about, and making the appliance there. But we all know, like Matt keeps going back to, this is a mid-face deficiency issue in adults and teens. So the appliances we're making are just like the glasses you put on your eyes to help your eyesight. It's just a tool to help the poor eyesight. Our orthotics are a tool. They're not fixing the problem. Fixing the problem, we now talk about getting rid of the different oral appliances, may involve surgery, preferably not, will usually involve orthodontic treatment to move the teeth into this correct position, or sometimes if it's bad enough in an adult, may require surgically to advance the maxilla and the mandible forward, to help things out. I think that summed it up.
Yes, and so my oral surgeon, and there's a distinction between having surgery on the jaws and distinction of having surgery on the joint.
Great point.
So the joint to me is taboo. You don't touch that joint. You just put the lower jaw and the upper jaw in right relationship and let the body heal that area.
Mhm.
So when a
Great.
surgeon does do surgery here, then they have to have a way of putting the upper and lower teeth back together again.
Mhm.
And what they do is they use Pete Dawson's technique of putting the joint up and back into the, where the condyle goes. After the surgery and people heal, they're too locked in.
Mhm.
So surgery is, to me, always the last way to go if you could wear this orthotic that fakes the brain into thinking that you have a good bite. And if that's all you want to be is out of pain and feel normal, even though you have to wear the appliance, it's a pain in the rear.
Mhm.
Sometimes that is the final solution.
Sure.
And if the book that we're writing is going to be about the zone of TMD freedom, and I used to tell my patients, if I have to adjust you 3 times, you'll need to see a chiropractor or somebody to help you because you have other issues in order to get you into that zone of comfort. Because all of this is connected,
Right.
and as you well know, and that's for a whole different topic and a whole different podcast.
Well, when we're treating patients, we're really treating the front of the head. A lot of times we need to recruit different type of chiropractics or body workers, and we will talk about that too. I think that's a great topic. But can I go back to your surgery comment? Because
Yeah.
I really want to emphasize that what you just said. There are two types of surgeries that we're talking about. One specifically is like a joint replacement surgery of the TM joint itself, which 1 out of 2 times is completely ineffective. And I think that's very generous in saying that. And the
Yep.
other people need to know, like I know maybe 2 amazing surgeons in the entire country that can do that, one. And then two, just like with any joint replacement, guess what? The surgery has to be redone again. So be ready for that. And what are your odds with that? The other thing is an MMA procedure, which is a maxillary mandibular advancement procedure surgery, which is what I was alluding to, where they break the mid face that never developed forward enough. It's too far back, retrognathic, and they also break on both sides of the jaw. I'm pointing if you guys are looking at us on YouTube, but they break the jaw kind of like in the middle, and they bring the front of the face forward. If you notice when they're doing that, you will get improvement in facial aesthetics, like the profile, and it also helps get the tongue out of the way of the airway, so people can gain great ground with that for sleep issues. However, it never changes the position of the joint, because that's not, they're not touching that. So if a patient comes to me with facial aesthetics concern or airway issue, and it's an adult that's kind of a little too late in some ways, I'll say, well, why don't you go have your MMA procedure done first? But understand, you're probably going to come back to me for your TMD symptoms that you suffer from, and do that. Or if the reverse, their chief concerns are all the pain issues, they want that fixed first. Okay, let me make you an orthotic splint so we can see how much of your quality of life improves, get you out of pain, right? And then wait, let the body adapt to that. And then I have my surgeons put their jaw into that position.
And that's why a brilliant Irish Shapiro who wants to copyright this, trademark this, is that what we do is a diagnostic neuromuscular orthotic, because you have diagnostically found the correct relationship between the maxilla and the mandible with your orthotic. And you're giving your surgeon a guideline. Hey, I want these jaws to be in this exact position when you're through.
Yeah.
And here's another little tidbit is I was meeting with a pulmonologist on sleep, and he told me 30 and 40 years ago, they were doing mandibular advancements for sleep apnea surgery.
What?
Yeah.
I did not know that. That's good.
I didn't either.
Why
Yeah,
did they stop?
because we came out with pieces of
CPAP.
plastic that works as well. Yeah. It's CPAP, the CPAP.
Hey, Matt,
So, hey,
you just came back from a conference. Speaking of other doctors, like you just came back from a pain conference, right? I was out of country, but you just came back from one.
while you were on a beautiful island looking at the sunset and the sunrise and the mountains and stuff, I was sitting in a boring lectures, scientific, I'm the last thing I am is a scientist. I'm a clinician, not a scientist. But yes, it was a very interesting meeting. And my hat's off to the American Academy of Oral Pain because they have done a fantastic job of making what we're trying to do into a specialty in dental school. The only way that dental schools are going to start teaching TMD, which I completely missed out on and you missed out a lot, is if it is a specialty. So my hat's off to them for doing that. They do things a little differently. I can't really say what they do because I haven't done it, but here's what I can say. I know what I do works. I know what you do works. Curtis, Alex, Priya, all of us that are friends, all of us that are on the board of ICMO, we all have the same dialogue. We all have the same results. So we know what we do works. And nobody can dismiss that from you or I. There's no way they can. So I'm going to be open-minded enough to say, if the AAOP has been able to establish this 12th specialty in dentistry, they must have some kind of a success. So I can't dismiss what they do in any fashion or form. It's the same for the Dawson Academy. It's the same for Pankey. It's the same for all these different camps. They wouldn't still be here if they weren't successful to some degree. I can also say my experience of being through all those Pankey, Dawson, Coyce, et cetera, neuromuscular, but not through AAOP, I can say that what I do works vastly superior than what I did in the past.
Right.
And as a clinician, that's all I can say. I can't discount, I can't disprove, I can't talk bad about anybody else. There's a big movement now, and I have to hats off again to the TMJ Association, which is working with the government. And the whole focus of the TMJ Association is to make your sufferer, the ones listening who are suffering, to make your TMD problems to be an awareness campaign. and to go to the government and get funds and money to be able to do scientific studies on what you're suffering through each and every day. So there's light at the end of the tunnel, but we all must start working together for this to be a fact.
Yep. Putting away again, put away the ego, amigo. And
Put away the ego.
um, that's really important to highlight is that, you and I and our colleagues have never had the mindset that what we do is the only way. We just know that it works.
We know that it works.
How we do it. We do not mess around with people who are suffering. We do not want to make them feel any worse in any way. We want to get them out of pain. And maybe sometimes patients they can't afford treatment with me, right? It's always a possibility.
Sure.
Or they won't
Absolutely.
tolerate oral appliance at all. Maybe just don't have the time, so, you know, fundamentals with the AAOP is like, using injectables like Botox is huge. There's now like, what is it called? Like the TMJ protocol for Botox that people are using all in my area. Or they'll use different pharmaceutical prescriptions, to help again dull or nullify what the body, like the neurologic feedback the body's trying to give, so you don't feel that pain. And sometimes, people are going through a divorce, or work change, or they just had a baby, and those are good. Those are good options. They're valid options. But again, those are temporary fixes. If the root cause of the problem is not diagnosed and addressed, it's going to come back.
So I had a young female patient, hairdresser, years ago. Well, not that many years ago, but came to me. We did the orthotic that you and I are talking about. Immediately got her out of pain. Immediately. And did not hear from her because I'm really a specialist. Once they come to me, they go back to their regular dentist. So I didn't hear from her. And then I saw her name on the books and I was so confused. And she came in and she was only with her appliance in, only hitting here on the front right side. The only place she's hitting, her headaches were back. So did a T-scan, both with the orthotic in and with it out, and T-scan measures the bite. And she was, in true, hitting only on the front right.
Mhm.
So then we put a TENS on her, and that's the relaxing equipment that you and I both use. And in 20 minutes, she was hitting back normally. Again, 20 minutes.
Right.
So I walked in, I said, this doesn't make sense. Allie, what's going on? What's going on with your life? She said, I'm going through a horrible divorce. So the TMD is not just about the bite. TMD is about the whole body. Where you are with your bite, where you are psychologically, where you are socially, which means you can afford it or not afford the medicine. But we as doctors treating you, people who suffer, that is our responsibility to be able to know what's going on and be able to help you. But it's a true rewarding experience to do what you and I do.
Yeah, I totally agree. It's high fives and hugs in my office, but can't imagine
That's
doing
right.
anything else. But I will say this as we wrap up here, Mac, our orthotics, I want our listeners to understand this. This isn't some magic tonic or snake oil, okay? It doesn't make the whole world a happier place and your life a happy place. What it does is that it restores balance to where your body functions. And when you're out of that type of pain, you're able to handle all of the other life stressors. It's not to say you won't get a headache again. It's not to say that you're going to be happy every day. We're just taking out this one nasty splinter that's been festering in your life all this time and giving you a better deck of cards to play with.
And that festering splinter for you and I is easy to identify
Yes.
because the joint, the muscles, and how we do our diagnosis and how we do our interviews, easy to identify. I have to take it up to be on the AAOP side that that's not the only thing that causes pain, head pain. You have your migraines, your trigeminal neuralgia, you've got tumors, you've got a lot of things that it takes, when I see something that doesn't fit the muscles and the joint and the thing we've been talking about, it's a referral. I want to send them to somebody that knows something more because you could be dealing with some dangerous stuff.
Right.
So I have kudos to the AOP for bringing all this to light.
Well said, Mac. All right, so what do you think? Next time we'll talk about tongue and myofunctional therapy and for any elective.
Ooh, absolutely. And if there's a Facebook site, it's called TMJ Discussion. Get on and you see me on there and ask questions because
You're
we'll,
very active on it, and I love your
yeah.
responses. I'm not
Well,
as good as you are.
well, I'm retired, Pam. I'm retired and I don't have kids at home. So it makes a difference. But the thing is that we want to use these first podcasts to set the rules of what works and what doesn't work,
Mhm.
and then have you ask questions so that we can refine our message to you that is
Yes.
more delivered to people who have the same problems that you have. Because here's the thing, all over the world, and I've done podcasts and Zoom presentations all over the world. In India, the patient's symptoms and treatment is the same. It's the same in Russia. It's the same in Israel, Syria, the UK. What you have is real. What we do works. We got to get the two together in some fashion or form.
Agreed. Agreed. All right, my friend. It's great chatting with you.
Good chatting with you, dear. Later,
Next
next
time.
time.
Bye.